Welcome everyone. I understand that most of the people are in the United States, but we do have a few attendees from overseas, I should say actually other continents as well. So thank you for attending and welcome on board. I'm just making sure that the slides are now visible. Perfect, thank you. So I really appreciate having this hour with all of you to kind of just share some of my experiences and learning of why I love neurology, why I love epilepsy as a subspecialty of it, and then also to tell you, I'll start off by telling you a little bit about myself and then about neurology and then epilepsy. You're welcome to ask any questions for chat at any point in time, and I'll do my best to get to them either during the talk or at the very end of the talk. So thanks again. So epilepsy and neurology. I recognize that many of you are from third or fourth year medical school, also from Tulane, which is in New Orleans, which is where I did my fellowship. For some of you who may not necessarily be very well versed, just to kind of give you an idea, neurology, of course, is a 4-year residency, and then epilepsy is one of the many 10 plus subspecialties you could choose. It could be a 1 or a 2-year fellowship. So before we get into that, telling you just about me a little bit. All right, that worked out. So before you hear about me and my work as a white coat, just to kind of let you know that yes, as neurologists, we tend to be nerdy, but we do have a life outside of work. And this was just a picture. It was a girls' trip in a museum and a gala, and just a very nice evening. So just a reminder that yes, we have a life at work, and you see the white coat in the background, but we do have a great life outside of work as well. I did say I'd tell you a little bit about myself. So I am a neurologist, but outside of that, I'm a hybrid of different cultures. So I went to Montessori school here, and then my parents, who are originally from India, took me back to spend time with my family there. So I did part of my education there. So I feel like I got this really great blend of 2 different cultures, medically, socially, culturally, which was a really fascinating experience. So for as a result, for anyone on here who may be an international medical grad, I'm certainly happy to try and answer some of those questions as well. And then before we get to epilepsy, of course, we're going to be talking about why did I decide to choose neurology? So all the way through medical school, it was clear to me that I wanted something that was going to be intellectually challenging. I love medicine and patients. As you know, the first thought you decide is it medicine or surgery? So personally for me, I said I don't have the dexterity of a surgeon, and I love to be able to talk to my patients and have meaningful conversations, which being in an OR sort of limits that. So that kind of made it easy for me that it's got to be a medical specialty. Now, within medical specialties, I enjoyed every rotation, but I noticed that one organ system that stood out to me during each of the basic science courses, whether it was anatomy or physiology or chemistry, it was neurology, which was a recurring theme. But I didn't really narrow it down yet. During my electives and as an MS4, I recognized that during my neurology elective and subsequent SEBIs, the cases which had to do with neurology were the most fascinating to me. And I like the detective work, so to speak. I know that's something you might have heard of, that it's a puzzle that you have to solve. A lot of different specialties have amazing things. For me personally, I like that in neurology, you can have all the data you have, yet that data alone won't give you the answer. You still need to talk to the person. Sometimes you have to be a detective and dig into their family and talk to other members. You can pull all of the pieces of the puzzle together, but still it's not always a crystal clear answer. For instance, it's not like doing an ultrasound of a kidney and you have an answer. You need to get the picture MRI of the brain. You need to get the brainwave test. You need to talk to the family. You need to kind of go backwards and figure out when the problem started. So the idea of this digging into one's life and getting to know them as a whole person, not just this one patient in front of you, really appealed to me. And I love making connections with my patients and being able to see how they're doing over different periods of time across years. So clearly when you do that, a specialty like ER or anesthesia perhaps isn't for you. And with everything combined, neurology was a specialty that just really spoke to me as a person. And coincidentally, my mentors also thought that it would be a good fit based on how I was doing in school and the things that seemed to attract me most. So that was a little bit about why I chose neurology. And so I did mention to you that I've had the pleasure of being in 2 different cultures. So as part of that, I did do my medical school in India, but I decided to do my residency here. A big reason was simply because it always felt like home. A big part of my childhood was here. And so I went through the whole residency matching process. I was still not certain if neurology is the best fit, or knowing that I love spending time with their family, patients, dynamics, would psychiatry be a good fit? But it was really amazing to learn during residency that neurology has a lot of interplay with psychiatry, and that's something I'll talk about a little bit more. And during residency, it really solidified that being able to talk to your patients, manage them, work with surgeons, and help them at work, but also in their day-to-day life, whether it's as a truck driver or a teacher or an attorney, is something that I really enjoy as well. So then kind of pivoting a little bit into the subspecialty, why epilepsy, why not something else? There are a lot of different ways of kind of coming to that decision. Um, for me, and based on the feedback I got from faculty, it makes sense in your second and third year of neurology residency, second or third year residency, meaning out of the 4 years, but I should say first or second year of the true neurology residency after the internship, to try and see what really suits you. So of course you enjoy every rotation, you participate in wholeheartedly, you learn from every case. But it's a good idea after the first 6 months of that residency training and getting into the flow to kind of take a step back and see, this 4 or 6 week rotation, is it something I can see myself doing for the rest of my life? Is it something that I find exciting, challenging? Would I enjoy this 20, 30, or 40 years from now? So that kind of helps make a decision. And honestly, epilepsy was not a sure-shot decision that I made at the very beginning. I played around with an idea of, should I do neurointensive care? I love the idea of helping really critically sick patients get better, and I love the idea of working with different teams. But towards the end of that year, I said, I love working with sick patients and helping them get better, but I don't know if it's for me to only see them at their worst stage get better, and then I don't know what happened, because as an intensivist, I only get to work, or neurocritical care, I only get to work within a hospital setting. Again, that may be great for a lot of people, but it wasn't the best fit for me. So kind of going through that process with different specialties, including movement disorders, behavioral neurology, stroke, what I liked about epilepsy is being able to help people in different aspects of their life. You might have noticed that I have this theme of wanting to get to know people in different aspects, different times, and perhaps coming from an exposure to different cultures also blends into that. Sometimes we think of epilepsy as being something where, you just help a person go from extremely sick to seizure free and that's it. But the reason I've kind of shared these pictures of Susan Boyle on the left, who we hopefully many of us may know is a talented singer, and of Shonda, who's an amazing hockey player on the right, is simply to illustrate and remind us that you can have a really wonderful and fulfilling life, even if you had or have epilepsy. So it's not necessarily just about make them seizure free and you're done, but it could be really fulfilling to help them through the whole journey. And another thing that's exciting about epilepsy is not every patient is the same. Not every day is the same. What do I mean by that? I don't mean to take you back to your medical school study, but just a quick reminder that the same electrical discharge that causes a seizure can have different presentations of different body parts. So the very reason I like neurology about the detective work kind of comes in here as well, because a person himself or herself will simply say, I passed out, or I blacked out, or I don't know what happened. But that's where it's truly digging into the family history or others who were there or what happened first, and trying to work your way backwards, kind of come to a guess of, okay, this is where I've narrowed down to where the lesion is, which is probably something that most of the MS4s on the call would have heard from the neurology faculty, and then use the other testing to decide, okay, is this the best way for us to move forward in terms of diagnosis and treating one seizure? So this is more talking about like why I like the diagnostic aspect of epilepsy, but there's a lot more to it. For many of you who may be thinking, is this going to be a good fit with, is it a busy life? Is it a paced, predictable thing? I'll come to that in a few moments as well. But before that, I just wanted to say, with COVID, we've all really accelerated our work with high tech, and epilepsy specialty really fits into that well. What I mean by that is that you can do a lot of high-tech things, ranging from MRIs to SPECT analysis to a lot of different kinds of new and cool imaging. There are a lot of different technology that even the patients can use to keep track of their seizures, alerts, triggers, which I'll kind of hopefully get to towards the later part of this talk as well. And you get to be a part of this journey for them. So for those of you who really value developing long-term relationships with your patients, whether it's from childhood to adulthood, or whether it's from someone who was employed, now can't work because of seizures, getting back to that, or helping someone through the part of, it's scary, I had a seizure, I don't know what to do, to the different testing, how can I embrace technology and or treatment options, how can I work with a care team to help them get better, this could be a really exciting and rewarding team. and an exciting process. So I mentioned about high tech. These are just two of the random examples that I chose. One is just to say there are a lot of different apps through which patients can keep track of things. Of course, this is true for any neurological or other condition. But the reason I highlight this is what we take for granted today, having all of these apps and ways of patients or family members or doctors being alerted to someone's seizures didn't exist a decade ago. Even 5 years ago, it was not a commonplace thing. So epilepsy is not simply seizure, give a medicine, or do surgery and you're done. It's a field that's evolving. For some of you who might have heard about neuromodulation, we have so many cool devices that you can place on the recurrent nerve called a vagal nerve stimulator, or you can place on the actual brain just inside the skull called RNS or NeuroPace. So there's a lot of cool development happening, which is really exciting. Or the Embrace Watch, which is all about alerting the family to when someone has a seizure so that they can also sleep and not be fearful every day of what their loved one is going through. And I mentioned earlier that I'll be sharing that how is this a team approach? In medical school, I'm sure you've seen, it takes a family to accomplish anything, whether you're working in your modules, whether you're doing casework, whether you're learning on service, different teams. So in neurology as well as in epilepsy, it's a team approach not only within medicine, but truly to care for your individual patient. Let's say you decide on medicines. It's amazing how you can have pharmacists, social workers, other teams really help out in making sure that they're on the best possible medicine with the minimum side effects. Or as you see here, a lot of different treatment options. What if they get an implanted device? They will need a surgeon, they will need post-operative care, they will need a nurse navigator to hold their hands. If they go for dietary options, which is usually more for a younger patients, meaning younger than 18, they will need a dietitian, they will need a pediatric neurologist. So you have this really exciting ability to have different people intersect, collaborate, and care for an individual, which makes that individual with epilepsy also feel cared for. And it's not just I go to one appointment and I'm done, but it's actually a whole team or a village, so to speak, that's helping take care of me. And the same holds true for whenever they go for surgery. You might have heard of something called an epilepsy surgery conference, where we meet along with the epilepsy surgeon, the neuropsychologist, psychologists, caseworkers to see what are the best options for this individual. And during this time, how can we best support the patient as well as their family or the caregivers who will be helping out with them. So at this point, before I continue, I just want to pause and see, are there any questions that AN staff would like me to take, or do we want to wait till the end? I'm assuming that,
yeah. It's up to you if you want to answer any questions in the chat. I'm not sure if there are any right now.
Okay, I will continue for now then. And again, please feel free to add questions to the chat and I'll be happy to address them. So we talked about the true team approach, and something a lot of you may be thinking at the back of your minds is, well, are we talking about doing, because you talked about surgery, so do we have to, does this mean we'll have life as an inpatient neurologist, outpatient neurologist? And that's the beauty of epilepsy. There is a lot of room to get creative with how much do you want to work in the hospital? How much do you want to work in clinic? Usually, most people who choose to have epilepsy as their specialty, epileptologists, will be spending 10 to 40% of their time in the hospital throughout a year. That could include seeing all kinds of inpatient ER consults, ICU consults, floor consults, and admitting them. Or it may simply be running an epilepsy monitoring unit, whereas you'll have anywhere from 4 to 20 patients who are undergoing a process of extended EEG monitoring to kind of help capture their seizures and help determine, are they surgical candidates? What's the best option? And that data is then taken to the epilepsy case conferences. Now, I said that many will choose that. I say many because there's also an option for an epilepsy specialist to decide to only work as an outpatient. I just want to do clinic. I'll read a lot of EEGs. I'll cover colleagues if needed, but I only want an outpatient life. So that flexibility exists, but most choose to do some inpatient as well for a variety of reasons. One of the biggest reasons is if you're an epileptologist, you do like looking at brainwave tracings. And the best way to be able to do that and truly follow your patient all the way through is not by just reading the outpatient 30 to 60-minute recordings, but also having them come into the hospital and see how they do, how their seizures manifest during their 1 to 5 day stay in the hospital. But again, there are a lot of options. And for some of you, if you're wondering, this just sounds like just read EEGs and go home, it's not exciting enough. I personally chose to do more inpatient as well as clinic and different things because I do like a bit of variety. And that's another beauty that epilepsy does tend itself to. So when I say variety, there are those stable patients that are coming in for diagnostic evaluation and it's an elective admission. But then when you're on inpatient services, you also see status epilepticus, which as you know is a medical emergency. And some of the seizures may get better right after giving them 1 or 2 antiepileptic medications, or they may end up needing ICU and intubation and much more aggressive treatment. Of course, we never hope for it. By excitement, I don't mean we want anyone to be sick, but by excitement, I mean the ability to intervene acutely and see how it really changes the quality of life and what an individual is able to do afterwards. And in terms of workload, as you can imagine, the workload would, I'm not quite sure what the questions would be, but in general, I would say that if you're on an inpatient service, you will perhaps have a stretch of 7 to 14 days where you'll be working every day, followed by a time of rest. Whereas if you chose to be outpatient, usually it should be a Monday through Friday, and then your weekend will be off, or based on where you're working, you will have 1 out of every, say, 6 or 8 weeks where you're covering those inpatient EEGs. And that's another beauty of epilepsy, that a lot of things cannot be done remotely. So for instance, you cannot embolize a clot remotely, but EEGs are something that can be read remotely if you are not the neurologist or epileptologist who is supposed to be on call that weekend. So that in case that's a factor, that's just another thing to add in. And then I talked about the team approach. Another benefit of the team approach is that you have a canvas to create a lot of what you want with epilepsy. For some, that may be creating this, not just an epilepsy case conference, but this interdisciplinary clinic, which includes neurology, psychology, psychiatry. Because for any individual who goes from being able to do everything to having a very limited life without driving, etc., there tend to be a need for psychosocial factors to be addressed. There tends to be changes in mood that require treatment. So having that neurology, psychiatry, psychology, social worker, what have you, can be quite a rewarding experience. Another way to pivot that would be neurology, and if there are specific aspects of it that really appeal to you, whether it's pediatric neurology, so some of the genetic conditions for kids that come in with seizures and what their treatments may be, because a lot of those are rare diseases. So working with neurogeneticists across the country, or working with other neurologists and seizure specialists to see those things and collaborating in different networks is one option. Another option that I chose was working with gender-specific issues for patients in neurology. What I mean by that is women patients who tend to have very specific needs based on where they are in their life cycle of before puberty, pregnancy, planning after that, how to expand the family, or postmenopausal. So that's something that appeals to me. And so I decided to establish a subspecialty clinic working with our women's health director. And so a lot of patients who are planning on getting pregnant or have any of those very unique hormone related or women specific management factors are referred to me. And it's something which is just a niche that I enjoy. I like the variety on inpatient, but I also like having certain niches. And the picture you see here is of me and some of my colleagues and mentors just brainstorming about different women patient and neurology initiatives at an AN meeting 2 years ago. And if you noticed, you see a lot of pink. You see pink folders, you see a lot of pink, and that's not a coincidence. The person who organized this meeting just kind of wanted to remind us all of why we were doing this. So another aspect that I like is that in addition to being able to design what you do for the clinics or how much inpatient work you want to do, you can also decide how involved you do or do not want to get in helping that individual with epilepsy make a full recovery. What I mean by that is, of course, you'll do the basic requirement of taking care of their immediate seizure-related needs. But if you chose to, you can always branch out and collaborate in the community. So for instance, I'm in the state of Oklahoma, which for those of you who don't know is in the Midwest, right next to Texas, also surrounded by Alabama. And here we are a suburban population, but some places we're rural. We don't always have a lot of opportunities. So being able to work with our Epilepsy Foundation to make some of those resources available to individuals or families with epilepsy that can't necessarily travel or access, or like the Ivy League institutions, has been rewarding. It's not something which we have to do, but for many of you who enjoy advocacy or interaction or doing it now, I guess even through social media as another option, I'm a big dog lover. That's something I should have said at the very beginning. I've had big dogs growing up, German Shepherds and Collies. So another thing that you see down here in the picture, of course, is not me taken from the site, but there is a society organization called CCI, Canine Companions for Independence, that works with individuals with epilepsy and other conditions and pairs them with therapy dogs. So they go through the whole process of pairing, seeing if they're a match, and spending time with them. And that's just another thing that I enjoy. And I'm able to combine my love for dogs along with my work. So that's just another fun thing to do outside of work. And then other things that are of value to me are exercise, fitness, meditation, music, relaxation, and being able to offer that to help with the stress reduction for a lot of our epilepsy patients is something that I've tried to incorporate into our epilepsy subspecialty clinics. It's not a one size fits all. So for some of them, for instance, who are trying to improve their endurance or who are trying to deal with strategic parts of recovery, whether it's depression related to epilepsy and loss of employment, or whether it's pre or post-surgical when they're trying to get back to what they're doing, that's been another rewarding thing to do. Another thing I would like to add is what's really neat about epilepsy is you get to see the whole spectrum. A neonate can have an epilepsy as well as someone in their 90s can have an epilepsy. And just like they don't all present the same way, the reasons for all can vary from a one-time febrile seizure, which will never ever happen again in their life, to unfortunately a devastating brain tumor. But then also you have everything in between, which could be just 2 seizures in their life, they never have anything ever again, or you dig through the history, you do a lot of testing, and you find out that they have a very unknown or unusual genetic mutation that you want to try and track down and help them more with, or they have a surgical lesion, meaning a specific lesion in the brain that you can help access and resect and treat also. So I know it's a lot of different information. I'll pause here for a moment. I'm hoping that there might be some questions or comments at least, so I'll pause and wait for that.
There's questions in chat.
Thank you. So repeating the question, I'm going to give me just a moment to find. Okay, so what are the major research areas in epileptology? Great question, and thank you for bringing that up. So the major research areas that I've been focused on so far, in no particular order, have included women in epilepsy. So why is it that the need for epilepsy management is so different in women in relationship to whether it's during pregnancy, during postpartum, during puberty? How do you best control the seizures that occur in relationship to menstrual cycle? Now that research is being expanded into how do we best help our adolescent young women as they transition into puberty or then adult life? So that's one area. Another one is into the rare genetic forms of epilepsy. What the different risk factors are, what the inheritance patterns are they related to other genetic forms that were not known, which also includes all the channelopathies, which are basically genetic mutations, but trying to figure out the best treatment options for them. A third great area of research is for epilepsy and something called psychogenic non-epileptic spells or non-epileptic behavioral events. So a lot of research into their interplay, diagnosis, when they coexist, how do you best diagnose them, what's the best treatment modality for each of them. Another area is for those who develop epilepsy later in life, the interlinks between epilepsy and dementia or aging, whether it's an association or what the interplay is another area that is important. And then there is a lot of research going on into trying to prospectively collect, are there specific seizure semiologies and specific lesions that seem to have a strong correlation, and new diagnosis, or like, for instance, from certain lesions being able to say, you know, this seizure semiology is highly predictive of this lesion. Another area of focus is the newer devices that I was talking about that are coming up. Trying to see what are some of the, where all would it be applicable? So for instance, I talked about vagal nerve stimulator and NeuroPace, but a newer one is deep brain stimulator. It's been approved for Parkinson's for a long time, but since it just got approved for epilepsy, now there's ongoing studies to see who are the best candidates, how much do they benefit, are there other side effects which are actually benefits for their mood? So those would be a few major research areas. If there are any follow-up questions from the person who asked, please feel free to add that in the chat box. How did you collaborate with ACOG Gynecology OB? Fantastic question. I would say it took a couple of years. It's not a one step and one go. I reached out to my mentor who had a lot of expertise in this. It was easier to collaborate locally within my own institution. And once I was able to collaborate within my institution and have a funneled women's specialty clinic, then I chose to collaborate with our partners here in the community, including Epilepsy Foundation. And once you do that work regionally, and then sometimes opportunities open up, or you just kind of talk to different people. So for instance, here I talked to women's health and OB, and then nationally and in other institutions, I said, this is an area of interest. What are other opportunities that exist? And the ability to be able to talk about this at a national level, I would say, was a combination of the perfect timing as well as my interest and willingness to do that outside of the work, the way it was designed, and kind of work it into my interest. And then another thing that helped is choosing to do research projects related to that. So for instance, when you have papers, in my case, it was on anti-epileptic prescribing patterns in pregnancy. So things like that also kind of lend you to having more merit and being able to collaborate when you ask for it. One more thing there is, in terms of collaboration, it's helpful to know which way you want to go, whether it's publication or research or patient education events, or are you trying to spread awareness in other specialties? I chose to do a little bit of many of these, and I'm happy to answer in more detail if you just let me know in chat if that's something that would be helpful. Thank you for that question as well. Next question. What should residency applicants look for in residency programs to ensure that they can gain basic epilepsy competency as a general neurologist? There may be community hospitals with limited availability of EEG technicians or fellowship-trained epileptologists. Excellent point, and so true. I didn't get to talk about academic versus community, so thank you for asking this question. So what should applicants look for in residency programs? I would say that basic epilepsy competency, it is part of a basic requirement for graduating residency. So at a certain level, you will have that already. But I'll give you a few other factors that you'll probably want to ask or inquire of every program you choose to interview at, and then use that in your decision box. One is, do they only, so there are two aspects to epilepsy competency. One is the clinical, and then the other is EEG. So for the clinical competency, you want to know, do they have a dedicated epilepsy clinic? Do they have epilepsy surgery case conferences? Do they have interdisciplinary epilepsy clinics? None of these are required, but having these will give you much greater exposure and being able to see the whole breadth of complicated cases as well as straightforward cases. Another great question to ask would be, are they a referral center for epilepsy, or which is the closest epilepsy center that they would refer to? And there's something called NAEC, which is a National Accreditation for Epilepsy Centers of Excellence. So that's another good question you could ask. Now, please keep in mind that not every institution in the country can have the Center of Excellence, because you have to have a certain number of epileptologist faculties, EEG technicians, referral network, etc. And some facilities may not have these, but they may have a huge number of epileptologists and a large volume of EEGs that they do that could be equally valuable. So that was a clinical aspect. Then coming to the aspect of EEG expertise, knowing how many scheduled rotations you will have for epilepsy monitoring and how many electives you can design for that would be the most important factor. You will at least be given 4 weeks. That is a minimum requirement. Getting up to 12 weeks would be helpful. But if you choose, or if you're thinking about maybe practicing in an area where you'll have to read a lot of EEGs and you will have no help whatsoever, then honestly try and get more than 12 weeks or 3 months, meaning getting 4 to 6 months would be really fantastic. And I'm not saying that you have to do it as a dedicated 6 months of epilepsy, because that's not practical. But being able to build in the ability during a lot of your electives to read EEGs would be helpful. And that's something you can certainly ask of your faculty that interview you. Next question. With the increase in technology and phone applications, have you come across any that increase medication compliance, particularly in younger epilepsy patients? Great question. I have offered a lot of different ones. I have not gotten feedback on whether patients prefer one more than the other, but some that they have told me that they like a lot are Epilepsy Diary is one. And then even other websites like the Epilepsy Foundation one kind of cross-links into their own. And then I believe it's drugs.com, if I'm not mistaken, that I was pleasantly surprised to see that they have their own inbuilt way of being able to track the medications. In general, I have found that using apps is something that the younger patients tend to do more of, and they do give me feedback that it's helpful. One caveat here, though, is that those individuals who may be living by themselves and or may have less motivation, or they may be feeling depressed, they may not be the most motivated patients to necessarily adhere to medication. But yes, technology certainly has been helpful. And then sometimes there can even be electronic reminders from the apps, which can help. Next question. What are the tools you can recommend to start learning how to read EEGs as medical students? Fantastic question, and I don't think anyone's going to expect this of you, but certainly you'll get brownie points for knowing that. There are a couple of different primers. I do recommend them to my residents, but I'm not certain if that would be a bit too terse and dry. But at the end of the talk, I'll be happy to share some of those links with the AN staff so that they can distribute it to you in case you were interested. The reason I say it could be a little bit terse is that it will go into a lot of terminology that you may not be familiar with, but I think it's a great idea to always at least get some overall sense of what it's like before you actually start reading EEGs. And it's really wise to be doing something over time, because just that first 4-week rotation of EEG won't teach you everything. So being a little bit familiar with the terminology, what the electrodes look like, what a brainwave looks like over a year or 2 or 3 can be very helpful. And the next question, what is the most challenging part about being an epileptologist? All of your questions are really insightful and excellent. I would say more than one. So one challenging part is not being, so a lot of this also I think comes from your individual personalities. So if left up to me, I'd love to fix every problem in the world. So having individuals who I can get medication or treatment for, but they don't have any support system, or for a variety of reasons, I cannot help them get fully independent for reasons that are outside of my control and their control, and we've gone to the extent that the healthcare system can, I do find it really challenging. But that's more in the outpatient world. In the inpatient world, what is challenging sometimes is trying to find the fine balance of helping the patient be healthy and functional. Treating their seizures is not as difficult as finding medications or surgery that will not be disabling, the side effects that won't be terribly sedating, and where they can have a true amazing quality of life. And I think that would probably be the biggest challenge in both inpatient and outpatient settings. Because all of the anti-epileptic medications, the way they work is by blocking certain channels, whether it's sodium or carbonic anhydrase, and most of them will cause sedation and dizziness. And although it can be helpful in the acute phase, long-standing, it can be a challenge. Another challenge I'd say is for certain individuals who develop epilepsy and who may never be able to go back to that profession, it can be really challenging of how do you really help them cope with something which is no fault of anyone's and their heart. It's difficult to address. That's where having an interdisciplinary clinic can be helpful, but it doesn't always help. Make the patient feel like they're back to their normal life. And I guess one example that comes to mind is someone who was a pilot. So sometimes it's easier. So for instance, I was able to help an individual, a young lady who was unable to get pregnant. She actually had an amazing pregnancy and child, which is a great story. But then when you have someone with a very difficult job where the rules will not allow them to go back based on their condition, like a pilot or a diver or someone who's active duty, that can sometimes be really challenging. I don't know if that really answers the question and that's what was being asked of me, but that's what I would say. Personally, I would still do it all over again and I wouldn't want to do anything different, but of course I'm biased or else I wouldn't be in this specialty. I will add here though that if at any point you find that reading EEGs is kind of dry or boring or monotonous, or if having to deal with the whole psychosocial dynamics is overwhelming, then please think twice, because an epilepsy may perhaps not be for you. It's just another thought I'd share. Another question, what are some research innovations in epilepsy on the horizon? This is a great question. I would love to hear from the medical students on this one as well, because I know that you've all been exploring and may have some other ideas as well. The biggest innovations I'd say are, they're sort of on the horizon, they're sort of already here, which is trying to expand the deep brain stimulation guidelines or indications for treating different kinds of epilepsy. Trying to pivot and move towards non-invasive and minimally invasive treatment for your epilepsy. And then also some of the newer medications, which are several years down the line that hopefully will have an even more favorable side effect profile, meaning a lot less sedation or other intolerable side effects. Any other questions that the group may have? You guys are very engaged and I appreciate your time. Any AI research involving epilepsy? That is a great question. Yes, to a certain extent. I'm sure there is more than I know. The one thing that comes to mind is that there are certain EEG technologies called like quantitative EEG, et cetera, they use predictive analysis. So basically 10, 20 years ago, someone had to be watching the EEG for a patient that's hooked up to continuous EEG monitoring, let's say in the ICU for 72 hours, someone had to be watching it or record it, checking the clip every few hours to kind of try and what we call pruning or capture like the most important ones and have an epileptologist read it. But now in things like quantitative EEG, which I'm pretty sure would be AI, there are predictive algorithms that can actually give you a quick snapshot of what are the highlight areas without a tech looking at it 24/7 without pruning can tell you what are areas you need to go in and focus on. There may be other areas of AI that I'm not yet familiar with, but thank you for that question. I'm going to definitely have to ask my colleagues and learn more about that too. Another question, if we are doing research in epilepsy or neurology, are there any conferences you suggest we look into? Yes, I would. Are we talking about conferences at a medical student part of life or residency? I'll wait for the question answer to elaborate, but in the meantime, if we're talking, okay, so as a medical student, thank you for clarifying that. Under non-pandemic circumstances, I would have said going to AAN and the American Epilepsy Society this year would have been phenomenal. But even pandemic aside, if we're wanting an interactive conference, I think the virtual American Epilepsy Society conference could be a phenomenal resource. Please note, we'll probably have more than you need to know at this point, but it will answer all the questions you could think of what's on the horizon, what's AI, and it'll make you more familiar and it'll help you solidify, is epilepsy my jam? Does it speak to me, or is this something that I really can't foresee myself doing for the next several decades in my life? I'm not quite sure of the question asker what their exposure has been. So if they're looking for something that's a bit more niche, and if the goal is to try and learn more about EEG reading per se, then there are certain courses that are offered by Cleveland Clinic and Case Western that I would highly recommend. So the next question, what is the relative proportion of epilepsy patients to other patients in your practice? How much time do you spend in clinic versus hospital? Okay, fantastic question. So in addition to epilepsy certification, I'm also clinical neurophysiology certified, which means that for someone who's only practicing as an epileptologist, their proportion of epilepsy patients will probably be 80 to 90%. The way I chose, as I mentioned, I like to do varied things. So I do epilepsy and neuromuscular and some general. So for me, epilepsy is about 60%. How much time do I spend in clinic versus hospital? So I do hospital work for a total of 2.5 months a year. The remaining time is in clinic. And then the research and other things I choose to do, some of them are just a passion, or for instance, advocacy or Women in Epilepsy Foundation things. Those are all unrelated and outside of work. How has COVID-19 affected your inpatient outpatient work as an epileptologist? Great question. I must say that I'm not a huge fan of COVID. I'm sure no one is. But to me personally, actually, it's been really challenging because I know what I want to do for my patients and they're eager to get the testing done and get well. But anything that is not elective is unfortunately being delayed, all for great reasons. But how it's affected is it has delayed the elective treatment plan that we already had in place. So I had a patient who was all set. We knew they need epilepsy surgery. We had everything done. They were going to get admitted 3 days. The final pre-surgical workup and surgery was supposed to happen in April. And as of last week, we don't know when that's going to happen. So I guess that's affected the outpatient work also in a sense that the elective testing of MRI, et cetera, if it's non-urgent, is not getting done. Of course, anyone with any condition needs something urgently, but unfortunately, as you can imagine, different states and healthcare institutions are defining urgent differently. So in this case, status epilepticus or uncontrolled seizures would be considered urgent, but someone who's had epilepsy for several years, needs further imaging, unfortunately may not be considered urgent by the responding organization. Another question. What advice do you have for students who are preparing to apply for residency in neurology? Great question, a bit broad, so I'll share a few pointers and then please feel free to ask me more nuanced questions. I don't know if the question asker what their level is, so assuming they're somewhere between M1 and M3, my advice would be to get more exposure to neurology. One, to solidify that neurology is truly the right field for you, because most people I've found either love neurology or hate neurology before they decide to go. I mean, those who love go into it, those who hate it, of course, don't choose it. In general terms, I haven't seen as many specialties to be so divisive, meaning most specialties you may be indifferent, but you won't strongly dislike. So if you're in your earlier stage of career, I'd say please get enough exposure to make sure this is something you love and would want to do. And then assuming that you're at an M3 or 4 level and have already solidified and decided you want to do neurology, doing away electives right now is not an option. Having said that, there are a lot of opportunities for virtual interactions with faculty, students, and residents at other institutions. And that could be extremely helpful. It can be helpful in broadening your horizons. It can be helpful in getting to network. It can be helpful in getting exposure to clinical situations or programs that you may not have had on your radar. And another thing, which I would imagine many of you already have on your radar, is anything on your resume or as part of your life experience that really reflects your love for neurology can be helpful. Yes, it could be research, but that's probably not very practical in the COVID era. So anything that shows that you really want to consider neurology not just as a career, but a part of something that is going to be an important part of your life, whether it's a social media campaign for neurology-related patients, whether it's about trying to do something creative for patients with neurological conditions or collaborating with medical students or other programs is always a great idea. Now, again, this is not required in any way, but just perhaps thinking a little bit outside the box of how can we reflect our strong love for neurology in these unusual times. I hope that answered the question. If not, please feel free to tell me another question that I can better answer. Another question, what does the collaboration between, and you're welcome, what does the collaboration between epileptologists and neurosurgeons look like? I would call it a marriage of sorts, and I will call it a good marriage. So epileptologists have to work with neurosurgeons very closely. This interaction starts from the time that an epileptologist identifies this person has a lesion that likely requires resection, and usually they'll talk to the patient and their family agrees. So it's usually a collaboration that will start either in the clinic when you'll refer to neurosurgery, or at the Epilepsy Surgical Case Conference where you will be talking to them. And I call it a marriage because it's a long-term association. Most cases you will, especially if you're working in a large institution or academic center where you will be doing the surgery right there, you will be working alongside the surgeon for the pre-surgical workup. And many times the epileptologist will be present during the actual surgery itself. Sometimes they may be present even before, so that times when they'll be present is if you're doing an invasive EEG monitoring before deciding on the surgery, the epileptologist has to be present and give input on where exactly the surgeon should place those electrodes of request. Epileptologists, and I did this in fellowship as well, you may be present to help with the actual mapping and confirming that you are resecting the area that had the seizure, but then also trying to find the fine balance of not sacrificing the eloquent cortex, meaning the area of the cortex that's important for speech, memory, and or limb function that the patient said, I absolutely want you to preserve that for me. So that relationship with the neurosurgeon will continue. And long term, many of these patients fortunately do not require repeat surgery, but they do need to be followed by the surgeon periodically as part of the postoperative care so that collaboration can continue. Now, not everyone's going to be working at an academic or an AAC level 4 center, which means that an epileptologist's relationship with the neurosurgeon may simply be an electronic phone or paper referral to a neurosurgeon in a neighboring city or in the community, and there may not be as much of a true working relationship. Any other questions or any comments, any feedback, any other thoughts or topics that anyone on here feels that haven't addressed and are important and should be brought up or you would like to highlight? And while we're waiting, Ms. Gates has put a survey that we request you to kindly fill out. I'll wait just another minute or two in case any of you have any parting thoughts, comments, or queries.
If I may, this is Maggie with the Academy. Regarding what you were talking about as far as getting some experience with neurology during this time, we have posted in our Synapse group that we are launching a 10-week self-paced APP conference, but it's actually really great for medical students also. We're kind of cross-promoting it just because the content is very relevant and at a really digestible level versus some of like our annual meeting content, which is for, you know, people who have completed fellowship. So it's really awesome. It's 10 weeks. There's some outlines about it in the Synapse group for medical students. Medical students it's $75 for access to the content, and you'll have access past the 10 weeks to be able to look at again. So just a plug if you are interested in more ways to access some virtual neurology and, you know, hear from different faculty, especially given that a lot of us are missing out on sub-Is. I will shoot over some information, but again, it is in the medical student Synapse page.
Thank you so much, Ms. Rock. I wasn't aware of that amazing resource. That could be really valuable too. Thank you for sharing that. In the meantime, we've had a couple of questions come in as well. And thank you, Ms. Rock, for posting that information so quickly. So the other few questions, I have seen a lot of psychogenic seizures on my service. How do you recommend we treat these patients? Great point. The best way to support them is to be honest and candid, or I guess open about their diagnosis. There is a tendency by sometimes to kind of tiptoe around the diagnosis for fear of offending someone. But choosing to spend a significant amount of time right when the diagnosis is made, especially on service, can actually help that individual be more open, can help establish a rapport, and most of the times, patients are looking for an answer. It's not what the answer is, they just want to get better. So I really appreciate this question being asked because it's much easier to develop that trust in an interaction, which is the first one, where you have the proof of, say, the EEG or whatever the reasons are for thinking that it's psychogenic, and be able to discuss that with the patient. And in addition to that, ideally having the neurologist continue to follow the patient while they get plugged in with psychiatry, psychology, or other resources is of extreme value. Because, and this is something which I really credit my epilepsy mentor, Dr. Benson Owen, for really emphasizing that it's important to have your patient feel that you're there for them all the way through. And if I were to simply say, oh, go see, after explaining it one time, please go see psychiatry, bye, there is a possibility of the patient or family feeling abandoned. And it's interesting and rewarding to see that I find when continuing to follow up these patients along with psychiatry and kind of re-emphasizing why it's not a seizure, going over that, helping address other things, has reinforced their compliance or adherence with the psychiatry and psychology treatment. And the other thing I would also request is to confirm that it's truly a psychogenic seizure only, because some of the really deep low frontal seizures can mimic psychogenic seizures to the point that they're known as pseudo seizure. And also psychogenic seizures can coexist with real seizures, very strong association. So to make sure that we captured all of them and we're not accidentally misdiagnosing someone as only having psychogenic seizures. Another question, how often do you find yourself using knowledge from internal medicine, and do you collaborate with internists often? I find myself using knowledge from internal medicine a lot. Part of that is because the way I was trained in medical school, it was a requirement to have a very strong foundation of internal medicine, irrespective of the specialty you chose into, and that was strongly emphasized during my neurology residency training as well. Do I collaborate with internists often? Within the niche areas that I have chosen, yes, I do. And what I mean by that is I collaborate with a lot of internal medicine physicians as primary care physicians or subspecialists. So for instance, elderly individuals who've been seizure-free on the older generation antiepileptics that have caused osteoporosis, or we need to get creative about how to help them, we collaborate with internal medicine or endocrinology. for some of my seizure patients who have autoimmune encephalitis and some of the really unusual autoimmune diseases, I collaborate with rheumatology or sometimes even oncology, because I have to give them these very new immune therapies, checkpoint inhibitors that I have not seen as much. I use them once in a while, but our oncology colleagues use them all the time. And then, of course, for my women patients, OB is another collaboration, which it's not internal medicine, but it is another collaboration outside of neurology. And I believe those are the only questions. We still have a couple of moments, so if people want to take off, I completely understand. Never hurts to have a few extra moments, but if there are any questions or parting comments, would love to hear those as well. And I thank you all for attending and for being a very engaged and enthusiastic audience, and for inspiring me and motivating me and reminding me of why I came into this field. So I really appreciate it. And just a request to the AN staff that if there are other questions offline that the attendees would like to discuss, or other input I could provide related to residency or epilepsy or anything, you're welcome to forward those to me.
Thank you so much. I learned something, and I'm not even in medical school, so you did a really great job. So thank you so much. I will throw that assessment in the chat just one more time in case anybody missed it. Feel free to email me with any questions after, and thank you so much for joining us. Thank you, Dr. Singhal.
Thank you all. I recognize that I was a bit oversimplified at times because I recognize there were a lot of M1s in the group as well, but hopefully I covered something for everyone. Thank you so much.